time so far. I'd just like to sort of introduce myself, if I may. My name is David Hutchinson. I've just literally started as one of the trustees on the Leg Club. My background is nursing and obviously Huntley Healthcare, so I've done quite a lot sort of in the industry as well as nursing. Unfortunately today we were supposed to be having Leslie giving us sort of talk about changes within the NHS, how we interpret things and how we do things, and unfortunately at last minute she's had to pull out. So thankfully Dawn has kindly stood in and she's obviously been brilliant at doing that. I think Leslie had presentations and all sorts to do, but obviously we didn't get those either, so Dawn's ad-libbing. So I'll hand over to Dawn.
Thank you, David. Yeah, so my name's Dawn Stevens. I am the Head of Sales and Marketing for Sigvaris. I am also a registered nurse. So my background is A&E, community nursing, tissue viability, and then a lymphedema specialist as well, over the last sort of 20 years of nursing. So very passionate about lower limbs, I think it's fair to say. You know, my knees crack when I bend down, you know, from all the bandaging. So as David said, I've been asked to step in for Leslie. So obviously what Leslie was going to do is talk about prevention and about obviously the NHS long-term fit for the future document, and just really linking in about what we can do differently, changing our mindset a little bit as clinicians, and obviously helping to change the mindset of our patients moving forward. So have you all seen the NHS Fit for the Future document? No. Okay. You're not on your own, actually. Every group has said the same thing, you know, so it's there. So what I'll say is, it's a weighty document. It's more than bedtime reading, but there is a summary, okay, which is quite, that you can get online. And the summary explains it really, really well. So some of the things in there are what we've probably heard before, you know, in terms of what they want to do. But one of the things that they are saying is that actually now it's no good just throwing money at the problem. We've got to do something different. So they're talking about reform and everything, which is nice to hear. The other really exciting thing for me is that they have boldly used the word prevention. So one of their key strategies now, out of the 3 that they're looking at, is about preventative care. So not necessarily waiting and just treating the cause, actually looking at things from a much broader aspect, which is really, really great. They've alluded to it in the past, haven't they? And they've said about, you know, tackling obesity, tackling smoking, etc. But they've never used that powerful term, which, as you will know as healthcare professionals, prevention has always been seen as a bit of a taboo subject, because it's, you know, it's the spending money for the what if, rather than is it right to spend that money, whereas they're turning it on its head and giving us the opportunity to do something different, which I think is really exciting. So today, hence why we are in a circle, I thought it would be good to understand a little bit about your practices, maybe understand, you know, do you do preventative care? Is the blockers? What can we do to change it? You know, and sharing best practice, because obviously we can facilitate these meetings, but what we've found is that actually we'll start the conversation and you guys will just carry on, because everybody's got a lot to say about it. What I will say is, I've said it in every group, is when I started doing my nursing career and I started as a healthcare assistant on a general surgical, we used to laugh about the fact of when patients used to walk through the door, they'd leave their arms and legs at the door. And that's because we do everything for them. We almost don't empower them, because we take on the ownership of everything that they need to do. So part of it is almost giving them that accountability and that power to, you know, to take that responsibility, that accountability for their own health and well-being, and obviously their legs is part of it.
We've taken that on, haven't we, as prevention?
Yes.
I mean, we're getting patients to do more for themselves, and I think a lot of patients actually see that as like, you can't be bothered, so you're making us do it ourselves. So there's that barrier. But yeah, we do a lot. I'm doing it every day.
Yeah.
That's the, unfortunately, that is the model of healthcare, isn't it? Because all that they're doing is treating the symptoms. They're not going one back in the causal chain to deal with the root problem.
Exactly.
So I sent an 8-page document that I produced to the government last November, to the beginning of the year to get a reply. Sorry that you're, unhappy about so many things, but we don't deal with complaints. It wasn't complaints. I gave them
feedback.
I said what was wrong, what they needed to do, and it was quite comprehensive. In fact, one of my teenage grandchildren read it and said, "Grandma, I agree with everything you've said." And I thought, some of it was going back into senior schools and teaching them, first of all, first aid. When they start at senior school, they've all got to learn CPR, and bringing it back to, ownership of your own health. So we have to go back to teaching proper domestic science. And all they're doing, I was horrified when I went with one of my son-in-laws who's got FMD and he's now in a wheelchair. And the neurologist table was the size of a small double bed. It was 4'6". Now, when I was doing clinical sciences at uni, you learnt to examine from the left, and you could get. And I said to him, "My God, he said, I have to go right the way round. I have to do it from this side and that side." And also in the waiting rooms now, there are all obese chairs. They're dealing with the consequences of the problem and not dealing with the problem. So prevention is such a big thing. And if only they had and could understand the consequences financially for nipping things in the bud, dealing with the cause of it, then you think, I was having this conversation with one of the reps downstairs and saying, lipedema, for example, I'm quite passionate about. It's very misunderstood, and there's arguments between professionals with regard to diagnostics, with regard to what you should do with diet, what you should do with exercise, whether or not they should go into compression. So with that amount of confusion, when you have, a patient in the middle, how do we expect them to take ownership when they're going to get different conflicting advice depending on who they see and where they see somebody?
I've had patients coming in saying that the GP has diagnosed fat legs.
Yes.
Say they haven't had a diagnostic. Going back to prevention, to here and now, Manjaro, Ozempic, Wegovy. I know it's costing a lot of money, but
it's the easy option.
It's not an easy option.
It is for them. Because it's in their toolkit. And so there's so much pressure, but we don't know. Let's fast forward now. Take vaping, for example. That was supposed to be safe. We actually didn't need it in the first place, and that was one of the things that I flagged up. But because most of my patients that are vaping were people that never smoked. People that did smoke and gave up smoking because they can vape, nobody can smell it on them, and it's easy for them to do. So it didn't solve the problem in getting people off smoking. So we've now got teenagers, in intensive care because of damage to their lungs because they've been vaping. So we're constantly creating these issues. So how do we know pancreatitis further down the line? How do we know that these issues from using these GLP?
But it's, pesticides on foods, everything we do now, there's going to be effects, isn't there?
Yeah, but I suppose what could we do about the leg situation though? So on a prevention thing, I think, because that's the thing. So for today, we could look at, because there's the big problem, isn't there, with everything.
Yeah.
But if we think about our patients with lower limb wounds, and obviously then potentially we'd see them as very not compliant because they're not wearing the compression afterwards, etc. And many patients aren't very often non-compliant. It's usually because they don't necessarily fully understand what's being asked of them.
Yes.
So I suppose if we need to change our mindset a little bit on a preventative, what would we do differently now? Now we've been given the free pass.
Well, we have to go to when they're younger and get them moving.
Yeah.
Because if you think nowadays, kids actually don't do PE, they don't run around. If it's a sunny day, they have to sit under a tree because they can't go in the sunshine. It's ridiculous. So get them moving, sport is really important at an early age, because then you're naturally going to be fitter, hopefully, as you get older. You know, stop smoking, stop the vaping, get them understanding about food. So it's, you know, if you're asking what do we do for the future, that's what we do. We bring the next generation, because everything is static now, isn't it? They're all on computers, they're all on their iPhones, their iPads, so they're not moving.
So what, Chloe, I think...
Sorry, that's okay. I was just going back to lower legs. With our leg club, we have like a well leg part as well, so that's doing prevention, going on afterwards, not just self-care at the start, but keeping up with hosiery, maintenance, getting people in, like Live Well Dorset, we have come in, dietitians sort of come in and give, so they've got a group consultation environment, they all share each other's ideas, hosiery aids, how can we keep you going with this? And we also have like an exercise group, an armchair exercise group, so it gets people back once a month to get calf pump going.
That's sort of accidental learning, isn't
That's
it?
right, in a group environment where they share it, so it's a great hub for that sort of thing.
So you're almost doing the neighbourhood hub with what the NHS is trying to promote, which is great.
So really needing more leg clubs around here.
There's someone in Brighton.
Is there not? It really
definitely
is. Yeah, I bet.
And what do you do, Lynette?
Well, I feel a bit of an imposter today because I come from a textile background. I've only had recently my mother pass away with leg ulcer issues and was with her a long time. But one of the nurses, just relating to this session here, one of the nurses that was really good at doing the bandaging came in every round. She said, "Is that okay for you?
Yeah.
Is that okay for you?" And it engaged her. Yeah. And at the end of that, she left it alone because she'd been part of it, and it was just nice to have that. That she was fully engaged rather than.
And there's a lot to be said for that, Lynn, because I think sometimes it's the language that is used as well. So I treated one of my very close friend's mum. She had a leg ulcer at the hospital of Malio. She had it for 2 years, non-healing. The district nurses didn't want her to work. She worked in a market stall, you know, lots of different challenges. And I went into her and I said to her, I said, "So you're going to heal your leg?" And she went, "Oh, no, you're going to do it." I said, "Well, these magic hands are not going to do everything," you know, generally. And I gave her the ownership of, you know, actually, what could you do and what will I do? And we healed that leg in 6 weeks. And even now it's 8 years on, and when I speak, I still wash her my legs. You know, because ultimately she was empowered to...
Another thing, that one of the youngest of the recently qualified nurses came in and she said, "You are eating your vegetables, aren't you? You know, are you having a really healthy diet and eating lots of meat and vegetables as well? And and fruit, you know, make sure that you're..." And my mum was yes, of course, you know, but it was the first time I'd heard anything nutritious from anyone at all.
It is important. So I think there is things we can do that I understand. Obviously, we've got to look at the future. So we've got to look at the young generation, because that's the future.
Both ends, haven't we?
We have, but we've got this. Like I think you used the word static. We've got this static element as well at the minute. So how do we take those people and take them on a preventative journey? Now, it might be that they've already got an ulcer, it might be that actually they're healed, or it might be that we're just empowering them to take a bit more accountability. And it's about what can we do differently as healthcare professionals to take them on a journey with us, rather than obviously, because else it becomes very task orientated, doesn't it? And we go in, we do the same things, and it's very hard to kind of break the cycle. And obviously we want them to live their best life as well. That's the thing. So, how about you?
Yeah, no, that's like definitely giving lots of options, especially like you walk around, there's so many different brands and options and things, so it's making it really clear, I think, sometimes, like, this one might not suit you. This is the one we're going to try, hopefully.
It might take a couple of times.
But don't be disheartened, like, what, and we can well do it one way or the other, like, might start in a stronger one, and then see, or we'll try see how you get on. It's just giving as many options as possible and just reiterating, if that doesn't suit, we'll try something else. So then it's that bit of, there's no point, I'm not wearing them. So I might think these are the best ones. We try lots of different ones, don't we? So I know which one's my favourite, but that's my
personal choice.
Whereas I don't necessarily have an issue
Yeah.
bending down to put them on, or different things that they might, but things like that. So it's definitely letting them know that, and I think that's where well next month, because you've got that option to go, actually I'm not really getting on with this, because the amount of times you'll see them, and if they haven't come and seen you, they've like cut or done something lovely to them and tried to fix them themselves, and you're like, no, but I do have a better option. You just
And you open toe.
yeah, you do that.
What's the experience of, what's your best experience of the leg club for that you think has really made a difference to somebody or some aspect of what
I would
you've
think
done?
coming together and talking to each other
Yeah.
and sharing each other's journeys. Isn't that?
They're not alone.
Yeah, exactly that, and it really is. It is like a journey stepping in because it's a room where you go for your treatment if you come for that, or it might be prevention. I've got varicose veins. What can you do to help? But they come in, have the treatment. They'll have their social side where they have their tea and coffee and sit with everybody, talking to the other members. And then once they're through that healing area, we don't just discharge and never see you again. We like you to come back to the well leg, and then we can keep an eye, make sure you're ongoing care.
It's possibly the only time they get to see anybody as well, isn't it?
So that social really helps.
Yeah, they do their little trips and things, don't they?
Yeah.
It's nice when you sort of...
They go on trips.
Yeah, they're organising their... I think they've got a boat trip coming up, haven't they? It's like you say, it's like out another group of people, and sometimes, especially maybe if they're a bit conscious of, they might think, oh, well, my ulcer's actually a bit odorous or whichever, they can feel quite isolated. Whereas in there, but you can, it's, how was it, I don't know how others are set up, you can see each other's legs. So they are
no taboo.
Sat like
No taboo is
in this with each other. So you kind of realise you're not alone. It's that thing of, okay, you might be a completely different problem, but actually this is quite a, and we have what, between 60 and 70 on every Thursday. So you're seeing endless amounts of people of all different ages, with like 30-year-olds to probably 100. So it's sort of that.
It's seeing each other's wounds, like you say, and seeing actually they've got compression on and it's working, it's heat, there's a heat. Wearing that, it will. They can see.
And it's brilliant when you overhear someone say, oh, I like that, what you're using, you know, like the aid. Oh, where did you get that? Some of them say, I got this one off Amazon.
They've shown their creams, don't they?
Yeah.
And then they show each other different, because they're the ones that are doing it.
Yeah.
So they learn
That's
each
it,
other.
it's them doing the
So
work.
when the leg ulcer's cured, do you have some kind of certificate or
Promotion to well leg.
You need related to well leg.
That's the goal.
You do.
and keep your legs well?
Yeah, 12 or 3 or 6 months they choose.
And that, exactly.
So you've got the continuation.
Yes, and that's how long some of the hosieries, so one type of bar hosiery is 3, so 6, so then they get remeasured, they get their new set and they get their Doppler, so they don't, they're not wearing ones that have worn out too much and the wrong size. It keeps them up to date, with, which is that prevention side.
It is that prevention.
Because, okay, if they've not done that path and done the different route, they might come to the surgery and then they go, oh yeah, I've got compression socks, and they've had them 3 years, and you're like, that's probably not doing what it's meant to be doing.
So
now.
do you purely work at the leg club, or do you work elsewhere as well?
No, we're surgery the rest of the day, we just do one day.
You just do one day at the leg club?
Yeah.
So do you take the preventative vision that you see in the leg club when you work there, are you able to pull that into your everyday clinic as well?
Pretty much day one they come in with a wound and they're in compression.
So that it's great having the hub, isn't it? And the leg club on is amazing. But obviously, when you're seeing them outside of the leg club or another patient, can you bring that element into your practice?
So if you feel it would benefit, and they're happy to attend for the well leg or something afterwards, they're also invited to that. If they don't want to come to the leg club treatment section.
Okay. It's quite busy. It's a bit overwhelming for depending
Yeah.
Like some people love the social side and others are like, no.
Excellent.
I think that you hit the nail on the head about the compression, that because it's not a science, it's an art, really, when it comes to what's right for people. And a lot of the people that we see that have initially been put into compression at the GP surgery, it's always just medical. And then, like you say, they'll cut a bit off, or they say, well, I wasn't given a choice. And they're not always given a choice, are they? It's what they used to prescribe. And so compliance and preventing it getting worse, or maybe you're seeing something and you want to stop it becoming an ulcer, that's really important. And it's looking to see what else they can have.
The last group, interestingly, we were talking about, what about the other leg? What about the leg that's not affected? Because they're coming maybe, I mean, if they're coming with bilateral, that's different, but if they're coming with one
Some
leg...
patients choose not to wear one on the other leg.
On the other leg,
They don't particularly want to wear the one on the ulcerated leg.
No.
And you plant that seed on the first initial assessment. This is going to be lifelong.
Yeah.
This is what we advocate. Whether you use it lifelong is completely your choice.
Yeah.
But in an ideal world, we would like them to wear a pair. But
yeah.
especially through the hot summer months, they don't want to be wearing them.
No.
And you know, so that's really good with the choice of open toe
and the education. And it's all about the education, isn't it? And people having be able to make an informed decision on their own health. Obviously, they're gonna, we need to be doing things differently. But obviously, the great thing is, like I say, the fact that prevention is coming now, whereas before, if you'd have mentioned the word prevention, it's like, wow, because we don't do it. It's not something that the NHS has really kind of proactively done. So it's really just to think about, you've got an opportunity. We can't necessarily wait for all the policies to come down. We've got to be thinking ahead about what we can do differently. And it doesn't have to be big changes. It can be one small thing that you want to do that will just make a difference to how a person is prevented and lives without a recurrence of a leg ulcer. It's all of those smaller things. I think sometimes we spend a lot of time trying to deal with the bigger problem, and actually the bigger problem is 101 million smaller problems, and we've just got to chip away. And like you say, everybody's individual, everybody's unique, everybody's got their own thought process around it. So.
Also the ability to put the compression on, because a lot of the elderly that we see, they're arthritic, and even with the donning aids, you have to have a certain amount of agility to use them. And so that prevents maybe a compliance.
It's very, very evident in the area I work in. It's a very huge elderly population. People retire, come to Hereford, and even patients that get attendance allowance, have care, not carers, but have attendance allowance, they will not pay, or they have got nobody that can apply them for them. So once that district nurse, or because we share care, that district nurse or that practice nurse has finished with them, that's it. They don't wear them again, and then 6 months down the line, you see them coming back through the door.
I wonder if there's something, like Women's Hour, Radio 4, because that is a very the right demographic really for women to hear about these preventative measures, and to hear about leg clubs as well, to go and research what's what. To hear a conversation, hear a conversation on the radio would be really good, wouldn't it?
There you go.
To hear something.
That's an idea, and every group that we've done so far this morning, everybody's got different ideas and suggestions, and I think the purpose of this was, we could have stood up and done about, this is what the government's saying and this is what we need to do, but actually, I guarantee that every one of you will take something away from each other about what you could do or you could try, or it works in this area, I could maybe try this one thing, and all those small things eventually will make into something great and something big. It is.
Seeing somebody else doing it, or it just gives you that little spark.
It does.
It's planting a seed, isn't it?
It is planting a seed.
To grow.
It's planting a seed, and it's like one of the other groups we were talking about putting compression on. And there's a knack. There is a knack to it, and if you get the knack, it's great. But if we make it look difficult, because actually Mabel's our 7th patient of the day, and you know, you're ready for lunch, you know, and you're like, and you make it look hard, how does that pair the patient? They're going to go, wow, I ain't going to be able to do that before they've even tried, because psychologically they're going to be looking at us sweating buckets and just, you know, and all the rest of it. Whereas, like you say, so for me, I always used to use Donin and Doffinate, even though I didn't need to use them because I got the knack, because what it does is it shows the ease, so that then they can see the ease, because I think sometimes we forget that they're watching what we're doing as well. So it's hard, isn't it? Because you can't always be, this is going to be easy, especially if you've had a really heavy morning or afternoon, you know. So there's lots of things we can do. You were saying, weren't you, about, obviously, you don't mind me saying about, obviously, your health checks and that kick in, did they?
To be honest, I apologise for having to nip out and was interviewed. No, I was literally diagnosed with diabetes when I was 11. But in terms of prevention, that I had nothing. I mean nothing. All right, my blood pressure check sort of every year type thing, your routine thing at the GP. But it wasn't until I hit 50 that somebody even asked me to take my shoes and socks off. And you think, well, God, again, I've sort of over time seen 25, 30-year-olds, they smoke, they drink, they've got a real bad standard of living, and they're developing peripheral arterial disease. So they're going to be at huge risk. But until you start sort of educating them, and again, even through the diabetes clinics that I used to sort of attend, again, I've obviously worked closely with them as well. So you didn't really get education about long-term complications. So this whole policy whereby prevention is now sort of going to be the key thing, it should have been that years ago. And I still push this all the time, even in the clinic. I'll sort of say to the nurses, and again quite often as well, even now, they'll just stick their fingers on, oh yeah, you've got a pulse. You think, well, that's not quantifying anything. And they want me to sort of take you to Sigvaris pedis, and oh yeah, you've got a pulse. And you think, oh, really, my circulation could be getting worse and worse and worse. I could develop a leg ulcer in the next year. And then the cost that's going to imply, the time, the obviously issues that I might sort of then have, and I might then suddenly end up in compression for the rest of my life. Whereas preventative now, if somebody educated all that, it's all that thinking about sort of how we do things, and that's what's so important to me.
It's interesting. I remember in clinical sciences at uni, one of our professors saying to us as students, if you understand diabetes, you will understand medicine.
Absolutely.
Because there actually isn't a system that isn't affected when you have diabetes. So even something as simple as a routine eye check would pick up diabetes. Perhaps people don't realise it could go blind. So it's not just about PAD, it's other issues.
Yeah, to be fair, again the eyesight thing, again, I used to go to the opticians routinely. I'm kind of turning this around to me, I do apologise. Oh, you help that advice. In the day, so I was on holiday abroad once, and I went for my eyes checked, as you did, because it was dirt cheap, you could get cheap glasses, and they had a massive panic attack that I'd supposedly got all these issues in my eyes, and I was like, that ruined the rest of my holiday.
Yeah.
When I came back, I then sort of contacted my optician, and then I got involved with the hospital. And to be fair, they've been managing my eyesight ever since. But again, there was never that preventative check in those days. Like I have it routinely now, thankfully. But ophthalmics, I think, have gone down the prevention route way quicker than we have in terms of wounds.
But do you think part of that is the medical model? Because
Absolutely.
everything is dissected. So it's like lymphedema. Lymphedema will sit a little bit with oncology, with dermatology, with vascular.
Yeah.
So there isn't, and they're very tunnel vision in what they do. Never the twain shall meet.
Yeah.
So that is another, looking forward and talking about diet. But doctors do not get nutritional training, do they?
No.
So integration, maybe going forward,
integration, and those small steps in terms of the patient.
Communication.
Yes,
communication.
Just think out of the box and almost challenge things, I think is the important thing.
Yeah.
Because again, everybody gets blinkers. Oh, we do it that way.
Yeah.
And I know as nurses we sort of try and do things different, but again, sometimes you don't feel you've got the power. But unless you raise it as a problem, or raise it as a concern, or the potential to improve it, nothing's ever going to
Or
get
even
done.
just try something new. If
Exactly.
it works, you can shout about it. Sometimes it is just having the courage to step out of the status quo of what we're used to doing as well, because when you're in, and this is why these sessions are so good, because actually you're out of your normal environment, so you've got time to sit back and truly reflect rather than being in the midst of it. It's very hard to look back, isn't it?
I mean,
So
I'm
and
quite
sharing.
lucky in the way I work autonomously then. In a clinic, and I sort of look after my own diary, so I can give myself as much time to see each patient.
Yeah.
So, you know, although I'm lower limb, I've got close contact with dermatology, vascular,
So you're very lucky as well,
rheumatology.
yeah.
So I do sort of link in with these people. Getting things back from them is challenging at times,
But you've got the access, which is good.
but I'm aware that they haven't got the time maybe to be looking at individual different, you know. But it is quite frustrating.
So we're just, I know time's up. But we were just going to say about the sort of the whole Lindsay Leg Club type thing. I was just asked the question sort of how it would help and influence, and it's just that whole thing whereby people can come in and ultimately within, you go to a clinic, you're 10 minutes, you sat there, you go see your doctor, you come out. You've got sort of, you've got a whole time, haven't you, to be able to potentially, we've done your dressing, we've checked your wound assessment, but then from there you can explore other things and potentially refer on.
And that's also you've got to be able to, you know, be able to integrate something new, and if you're in a clinic where, I mean, these lovely ladies is fantastic listening.
I've got the leg club
because you're doing both, aren't you? And you're using that, which is fantastic. But if you're stuck in a surgery, they go, no, we always do it this way. Well, you're going to do a little own voice. It's going to be a lot harder. So I love the fact that you're able to do that and bring that expertise and want to be.
But I suppose now the good thing is if you have got that environment, you have now a point of contact and a share of voice to say, well, actually, it does work somewhere else. And you've got that peer-to-peer now, and actually you could support each other, and especially with people having difficulty, to share best practice, because actually you're not sharing a theory or a thought, you're sharing a model that works and somebody that can so it is about the networking as well, to make sure that you are all clumping together to share, because it would be great if the NHS was streamlined up and down the country, but it's not, and every patch works very, very differently. So, but
well, the systems are also different, so they don't talk to one another.
No, they don't. No, that's another conversation. That's another workshop.
Documenting thinking that hopefully the people will read it.
Thank you so much, guys. It was lovely to meet you. And
you did very well.
thank you very much.